Welcome everyone to our Compassionate Communication webinar series. I'm Gary Buckles, Director of Affiliate Faculty for the Sanford Institute's Center for Compassionate Communication. And joining us from the center in the background to keep things running smoothly and help me monitor the chat is Norma Nava. She's also going to be advancing the slides today for Lisa. And today we're very excited to welcome Lisa Williams. She is an advocate for well-being who helps organizations address the root causes of burnout and build cultures that support meaningful, sustainable work. She currently serves as Associate Dean for Well-being at the University of Kentucky College of Medicine, where she leads the Office of Organizational Well-being. With a background as a certified leadership coach, organizational consultant, and faculty member across multiple University of Kentucky colleges, she brings a holistic perspective to individual, team, and organizational change. She holds a Master of Science in Social Administration from Case Western Reserve University. And today she's presenting When Leaders Listen, How Clinician Insight Shapes Departmental and System-Wide Action. Welcome, Lisa.
Thank you, Gary. Good afternoon or morning, depending on which side of the country you're on. I'm really glad to be here, honored to have had this opportunity to share this conversation with you and a bit about what we're doing here at the University of Kentucky. Before I go any further, I want to start with a question. How many of you have heard, or maybe you've even said it yourself, something like, leaders never listen, nothing ever changes, or why should I bother giving feedback when it won't matter anyway? What I found is that this is one of the most common narratives people carry into conversations about culture, engagement, and well-being. It shows up in healthcare, it shows up in higher education. From my experience in industry, it shows up in corporate spaces too. And often, it's not really a statement about whether leaders care. Most often, they do. It's a statement about whether people can see a clear connection between what they say and what actually happens afterwards. Are leaders listening? I once had a physician say to me, very matter-of-factly, I've completed every survey they've sent me over the years, and I cannot tell you one thing that has changed because of anything I said. What struck me in that moment was not the frustration that I heard in their voice. I heard that, but it was the resignation that I heard that was even louder. It was a sense that participation in giving feedback, in sharing thoughts, no longer felt worthwhile. I think at the end of the day, that devalues our sense of belonging in spaces. That's the challenge that I'm going to talk with you about today. How do we move from collecting feedback to creating visible change? How do we shift the narrative from no one listens to my voice matters? And how do we do that in a way that is structured, sustainable, and rooted in trust rather than performative responses? Today, I'll share with you how here at the University of Kentucky College of Medicine, we've built an infrastructure that helps make that shift from no one listens to my voice matters possible. Next slide. Here's where we're headed today. So I want to, first I'll examine the benefits of integrating frontline clinicians into the culture change initiatives. And I want to emphasize that I want to emphasize integrating frontline clinicians. Are you okay, Norma, with the slides? Perfect. Okay. When we talk about integrating frontline clinicians, it's not just about asking for input. It is engaging frontline clinicians as the real contributors to defining problems and designing solutions. So this is the hand of those frontline clinicians instead of at the hand of leadership. I'll outline a framework that we've used here at the University of Kentucky to explore systemic drivers of burnout and distress at the department level, and to implement clinician-driven solutions. One of the things that we've learned is that if we move too quickly from data to solution, that we're going to solve the wrong problem. So I want to talk through a process that really saves time for us, secures time for us to really use data and understand root cause problems before moving into action. Thirdly, I'll discuss strategies for influencing system-wide initiatives through department-level interventions. And that connection is really important everywhere, especially in academic medicine, because many of the frustrations that people experience locally are shaped by conditions that exist at a broader system level. And if we only address issues inside one unit without learning from and escalating what they reveal, then we miss a major opportunity in system level improvement. And my hope is by the end of this session, you'll leave with some insights on our framework, I think a practical framework and a broader mindset that sees feedback not as a reporting exercise, but as the beginning of a change process that involves transparency, shared ownership, and visible accountability. Next slide. Before I move into the frameworks that we use, I'm going to give a brief introduction to UK Healthcare and the University of Kentucky College of Medicine. Just a bit of a context about our environment, because the context greatly matters in this work. At the University of Kentucky, we sit at the intersection of an academic medical center and a larger health system. That means our work on clinician experience and well-being is shaped by the realities of both the College of Medicine and UK Healthcare simultaneously. We're not talking about small, simple organizational structure here, and I'm sure that you do not exist in those small organizational structures either. We're talking about a very complex environment in which faculty holds appointments through the college while simultaneously practicing in the healthcare system. And this context matters because it shapes the challenges that affect engagement, fulfillment, communication, and trust. And they don't belong to one office, mine, or to one area. They don't belong to the College of Medicine or to UK Healthcare. They cross boundaries, they bridge. They're influenced by academic structures, healthcare operations, leadership practices, workflow. We asked you the thing about audio, so I'll see if this can get better. Let me know if it does not get better. If we're gonna shift environments and work on change in a really meaningful way, we have to operate with the complexity in mind. In my case, it's this bridge between the College of Medicine and the healthcare system. Next slide. UK Healthcare is Kentucky's flagship academic health system, and its scale is really important to understand because, again, that adds to the intensity of organizational strain and the potential reach for organizational improvement. We provide highly specialized care through multiple hospitals across our Commonwealth, more than 1,700 licensed beds and nearly 3 million ambulatory visits annually. Our patients come from all corners of our Commonwealth, often traveling hours to reach our healthcare system. Next slide. The University of Kentucky College of Medicine spans 4 campuses. We have campuses in Eastern, Western, and Northern Kentucky, as well as our central campus in Lexington, Kentucky. We have 25 departments within our college, with 18 of those being clinical departments. One of the central realities of our model is what I've mentioned already, and that's that physicians are hired as faculty members through our College of Medicine, and they deliver care within UK Healthcare. So when I'm talking to physicians about their experience, I'm asking them about their College of Medicine experience as a faculty member, perhaps doing research or providing education. And I'm also curious about their experience delivering healthcare on the UK Healthcare side. We can't treat them in isolation, which has happened in the past. right? We almost separate these individuals as two unique bodies, and they are not. They are one holistic individual experiencing their work in two different environments. And so we have to be mindful of that. We see, this conflict of demands from the healthcare side as well as demands from our college side that impact performance, it impacts well-being, it impacts how communication flows and how decisions are made. And so while some of the decisions feel very local to a division or department, they're always connected to this greater system of these two entities of the health system and the college. And so a collective approach was really important. If we want to improve physician experience in a lasting, sustainable way, right? I'm not thinking about solving the problem for right now. I'm thinking about solving the problem for later, for now and later. We had to create a process that allowed for really deep department insight, but also informed health system changes. And that's where we come in. You can go to the next slide. And is the sound better? Oh, it's good. Okay. So this is the introduction to my office. I'm very proud of our office. I established the Office for Organizational Wellbeing in August of 2022 with a full launch in January of 2023. We're a team of 5 members with varied expertise from organizational psychology and development, organizational systems and thinking, mixed methods research, program design, coaching, conflict engagement, and change management. From the beginning, it was very important to me that there was a clear distinction between wellness and organizational well-being. And this is important too for this talk because I think it helps shape the interventions that we've created. When I think about wellness, it brings to mind our resources and programs that help individuals build resilience and improve self. So things like mental health therapy, mindfulness sessions, fitness opportunities, financial support or planning, and other resilience building resources. Those things are incredibly valuable and they should be accessed. We should make them easy. I talk about that our responsibility in our office is to make sure that they're accessible and equitable. But they're not the end all. They are not sufficient if the work environment itself continues to generate distress. So our focus in our office is on organizational well-being. The onus is on the organization to examine the conditions in which people work, teach, learn, and lead. We think about leadership behaviors, and you can see here in our model for organizational well-being, the quadrants that make that up around leadership behavior, systems and structures, culture and connection, and individual support as all being equal parts of a really large ecosystem that's necessary to have organizations where people thrive. And so the distinction matters because it changed the type of questions that we were asking here. Instead of asking questions around how do we help people become more resilient, we ask instead, what in the environment is creating unnecessary strain? Where are people experiencing inefficiency, exclusion, lack of voice, or misalignment? And what would it take to address root cause conditions? Those are the questions that we sit around and ask as a leadership team within our college, within our health system, and that my team facilitates in the interventions I'm going to talk about. Our work extends across all of our clinical faculty, our basic science faculty, all of our College of Medicine staff, and all of our learners and trainees. And we have a very strong partnership while we're settled in the College of Medicine. We have a very strong partnership with the executive triad on the health system side, so we can help inform what that environment looks like, particularly for our physicians, but we're also having conversations around nursing, our APPs, and other staff. And so the ability to work across all levels became essential to the strategies that I'm going to talk about today. Next slide. So, as I mentioned at the beginning, one of our main challenges of our office was to address the very familiar feedback that you've likely gotten, and that's that feedback goes nowhere. So at UK, we've administered dozens of surveys over the time. We have facilitated listening sessions with the intent on driving improvement. We've done a lot of data collection. And in many cases, good things happen from those efforts. But there was a critical disconnect. Frontline faculty didn't see the results from the input that they gave. So maybe something was happening, but it was not being communicated down to frontline faculty. They did not hear about what was being considered. They didn't have an opportunity to provide input into solutioning. They didn't always learn about what actions were being taken, give input to what barriers existed, or how their voices overall shaped the path forward. And when that happens repeatedly, when you feel like your feedback doesn't matter, people begin to draw conclusions. They begin to believe that feedback doesn't matter. They may think that leaders don't care. They may think that nothing is happening, right? All reasonable things to think. They may start withholding honest input, or they may still provide their feedback, but without any hope. And that does real damage, not just to survey participation, but to trust, to engagement, and to organizational culture. And so what became clear to us was not that we needed leaders to care more. They cared deeply. The problem was that we didn't have a visible, reliable infrastructure that would connect listening with action in a way that people could experience. So we started asking more questions. What kind of structure would help close that gap? What would it take to create a more visible change from feedback to investigation to action to communication so that people would begin to say, I can see that what I shared made a difference. And so those questions changed what we did. Next slide. So the title of this presentation is When Leaders Listen, right? And that's what we developed. We developed a dual strategy that provided opportunities for listening to really happen. At the department level, we needed a way to engage chairs and division chiefs while also making sure frontline clinicians had meaningful influence over the process. At the system level, we needed executive leaders to be bought in. Our dean, our executive chief medical officer, our COO, our chief nursing executive, et cetera. We needed them to be able to clearly see and connect the large patterns that were coming out of our department level conversations. So this was not just a grassroots process. It was that, but it was also a bidirectional top-down process. It was necessary for it to be that, for change to be felt. If we focused only on local change, we could have some quick wins. We would have immediate problems that would be solved, but we failed to address the systemic conditions that keep recreating the department level problems. And if we only focus at the system level, there will be a disconnect likely from the actual lived experience of clinicians. So our approach became one of intentional linkage. We built a framework for department level change, and that's what I'm going to spend most of my time talking about today, and another for system level change. And we use them to inform each other. And this dual approach has proven to be two frameworks that really help leaders listen and change happen. You can go to the next slide. So the first initiative that I want to talk about is our department level framework. And we call those our Department Enhancement Projects, or DEPs. I'll probably refer to them as DEPs moving through this. This structure was formed really by two ways. First, it was informed through the scholarship of Dr. Tate Shanafelt and others, particularly in an article about the importance of unit level interventions in helping make meaningful impact on clinician well-being. Because when we focus on unit level interventions, they're close enough to the local environment to address what people are experiencing and feeling every day, right? So it allows us to get some momentum where people feel change. They're not just hearing about it, they're feeling it. We also leaned for depths on the philosophy of design thinking that promotes listening before solving. It incorporates the end user, in this case, the frontline clinicians, in the problem solving and solutioning process. It examines failure, which I love this. So we're really going to lean into why something would fail as a way to make it stronger. And then we move into prototyping for really rapid feedback so we can continue to strengthen the solution so it has scalability and sustainability. So we took those two things together, the work of Dr. Shanafelt, design thinking ideas, and we designed a process that fit our culture and our needs. At the center of it is a very simple belief. The people closest to the work are often the most or the best positioned to help define what is not working and what could work better. This doesn't mean that leaders matter. They do. But it means that in order for culture change to feel credible, for people to feel like their voice is being heard, we cannot treat frontline clinicians as passive recipients of the improvements. They have to help shape them. So DEPS became our way of structuring that work. This is not a quick intervention. The DEPS process takes anywhere from 12 months to 24 months, depending on the department and the issues that we're solving. It's not a one-time focus group. It is sleeves rolled up, all in to do this work. The process, I'm going to go into more detail about it, but it's also structured and flexible. So there is a shared sequence that will follow for each department, but it allows us to have some flexibility so we can tailor the process to the department's actual strengths, stressors, and goals. Next slide. This slide captures several of the defining features or beliefs about DEPS. I think the things that really make it work. First, as I mentioned, DEPS are individualized. We don't assume that one department's challenges are the same as another's. Even when they have kind of the same issue, like maybe engagement or communication, the underlying drivers can be very different. So we tailor the process to the realities of that local environment. Second, the problems are defined and the solutions are developed by the end user, that frontline clinician. This is a major design choice. Too often in culture work, leaders are the ones who interpret the problem and generate the solution on behalf of the people most effective. What happens with that is that crucial information is missed, and we often solve the wrong problem. You're going to hear me talk about that a lot of time today in solving the wrong problem. Third, we aim to test solution efficacy through best practices and rapid iterative experimentation. This means we do not treat ideas as final just because they sound good. We test them. We ask if they're feasible. We ask why they will fail so we can make them stronger, whether or not they really address the root cause or are they still addressing a surface problem and we need to get deeper to the root cause. And are they going to improve experience? Fourth, DEPS are not just about local improvement, as I've mentioned. They help us identify macro level trends that need to be evaluated by executive leaders. So while the direct work has to be within the locus of control of the department, we catalog the system level issues that we're hearing through DEPS and feed those up to executive leaders. And finally, the broader goal is not just to solve a narrow issue. It is to improve engagement, fulfillment, build community, help boost psychological safety, and build trust. So DEPS are a lot more about just a process, but they're really about rebuilding the social fabric of a department or a division. Next slide. This is the 7-stage process of the Department Enhancement Project. So while this process can be fluid, all 7 stages must happen. And there is some necessity for some specific sequencing. For example, we do not talk about solutions at the same time we're talking about problems. We start with data sharing. Whatever data we have, that might be Press Ganey data, it may be the AMA organizational biopsy data, other local metrics, pulse surveys, listening session, thematic analysis, whatever it is. And we share it transparently. It's not always been the case here. So we want to make sure that if we're going to ask for trust in a process, we give trust back. We share all data, good, bad, and ugly. We don't believe in hiding any of the data. It will not help us get to a sustainable end solution. So once we share data, we begin to pinpoint maybe some windows we want to look at based on what data is telling us. And we then move into the investigative session. An important part of this is that during the investigation session and moving forward through the majority of this process, we extract the chair or the chief from the process. And that's really important because it's not about excluding leadership, but it's about creating enough safety for candid conversations. People speak differently when formal leadership is absent. And that sometimes allows us to get to the root of the problem quicker. Other times, the chair may have a hard time interjecting what they believe the problem to be, even though they are missing context from maybe being the frontline clinician perspective. So during the investigation session, we do a series of focus groups where we really drive down to get to the why. And I'll give an example of something that started as a surface problem and we got to the root cause here shortly. And as I mentioned, we intentionally separate root cause investigation from solutioning. And this is hard for some people because they want to talk about a solution when they're talking about the problem. So we have some safe things in place so people can capture their ideas when they're talking about the problem. But we just want all the focus to be on defining the problem. We don't want to move too quickly into solutioning. In my experience, I've watched organizations move too quickly from that data to brainstorming, and they solve the wrong problem. And it just perpetuates burnout and feeling like people aren't listened to because they don't feel the difference of what that solution could be. After we have done the listening sessions, we do move into solution storming. A well-being coalition or a solution forming coalition is built and within the department, and that coalition helps further assess root problem and begin to generate ideas that are better matched from what we learned and address the root problem. We use principles of design thinking, as I've mentioned, here to really refine possibilities, to challenge assumptions, to look for failure, so we can build a really strong, sustainable solution. Once we have one or more solutions, we'll share those back with the global faculty and also reintroduce the chair into the process. And this is where we start looking for prioritization and sponsorship. We're going to look at, some feasibility and impact scoring. We're going to talk to the chair about any constraints that might need to be considered. We also talk to them about that on the front end too. So there's some things that are removed from possibility. Maybe staffing is something that cannot be solved right now. So we don't even enter staffing into the situation. But once we have a solution that's viable, we start thinking about what resources might be needed, et cetera, in partnership with the chair. And then we move into implementation and we start to evaluate. We examine whether that solution was it launched? Did it actually create a better experience? Did it address the root cause? And then we also help build autonomy for the coalition. So my team can go to another department and work on this, and the department then can begin to cycle through this on their own. So where have we done this? We launched our first department enhancement projects at the end of 2023. I know we're in 2026 now, but we launched these at the end of 2023. They took us nearly 24 months to complete, a little bit less than that. And we launched in our two largest departments. We launched in surgery and internal medicine. Since then, we've expanded into radiology, family and community medicine, and radiation medicine. And we have two division level department enhancement projects, division enhancement projects with breast radiology and some of our OB-GYN divisions. We chose to start in large visible settings intentionally. First, there was a question of reach. If we began in departments with high concentration of faculty, we could create a larger ripple effect more quickly. And second, one of those departments was low performing on our engagement data. And so it made a lot of sense for us to lean in and provide support for that department through these steps. Starting in these environments also served us well because we were starting in highly complex division or departments. Stakes are high. There are a lot of people. There are a lot of divisions with a lot of different kind of environments of their own. So it really helped us improve the department enhancement projects by starting in really hard areas. And it also sent a message that department enhancement projects could be used anywhere. They weren't only reserved for our high performing, high functioning, smaller departments. So I'll go into a bit of detail about those two depths. You can go to the next slide.
Lisa,
yeah,
we got a great question here that I think would be good to answer now if you can. It's did your system make a financial commitment to support these projects in addressing or implementing solutions? And if not, how have you overcome this issue to address the problem?
Yes, that's a great question. So in all of our department enhancement project solutions right now, the department had funds reserved through their quality improvement funds or other pockets of monies that they could spend on these efforts. So some of them did not cost anything to implement. It was just reimagining how things happened within their department, and I'll share about those. And for a couple of other things, it did cost some additional dollars to the department, but the chair had those reserved. At the system level, I'll go ahead and talk about, like, we implemented ambient AI, which we had not done until our first organizational action plan that came out of this work. And that was a very large investment from our healthcare system. So yes. Norma, you can go to the slide that says depths in action, the next one more slide from there. Perfect. So this gives some scale of what our first department enhancement projects look like. In the Department of Surgery, we engaged 138 faculty members, and we had a 10-member well-being or solution coalition. In the Department of Internal Medicine, there were 429 faculty members with a 23-member coalition. And together, those two departments accounted for around 36% of our clinical faculty. So we were able to engage a large percentage of our faculty within these two departments in the first two depths that we launched. And so, as I mentioned, these were very, there's a lot of competing demands, very big divisions, complex histories. It was a very hard and very great start for the department enhancement projects. And I think a couple things to think about here is that we talk about culture change as though it happens in these like sweeping statements. It's just like culture change happens, but in reality, it happens over a long period of time, and it happens with structure, with conversations, with representation, communication patterns, and this repeated follow through. And I think the depths process allows for all of those things to happen simultaneously. So while change is still evolving in these areas, it helped give a framework and kind of a quick path for there to be some change, culture transformation wins. And what we also saw in these departments, I'm going to go into more detail on them in a moment, but what we also saw in these departments is that they were talking to peers in other departments about the department enhancement projects. So the perception of being listened to was being transferred. People were talking about it. And so we started hearing people say things like, now there's a process for us to do something with our survey data. In fact, I just mentioned that I was doing a Press Ganey data share this morning, and somebody said, "Are you going to do a depths with us for this data?" So I think that that's also a lot of value, that people were feeling like they were being listened to enough that they were talking about it to peers outside of their department. You can go to the next slide. So let's talk a little bit about what it looked like for Department of Surgery and their depths. So at the outset, what surfaced most visibly were issues around communication. That's one of the things that probably sounds familiar to you, because that's communication issues, not frontline faculty not getting all the information to them from department chairs or even from organizational leadership. I think is something that's fairly common across complex organizations. But when we began the investigation process and we were sharing data and holding the focus groups and really listening to what frontline clinicians were saying, it became clear that it wasn't about sending more emails or holding more meetings. It was about fragmentation. Information wasn't moving consistently across divisions. People didn't always know where their concerns, where they should go with their concerns or where their concerns went. And we also identified that there were civility-related stressors and relationship strains embedded in the way communication was functioning. So we addressed some professionalism and civility while we also were thinking about structure. And so we separated root cause investigation from solutioning, and that avoided people from jumping to just fixing the poor communication problem, which might have been more emails, and that wouldn't have solved the problem. So the Wellbeing Coalition formed some solutions that were really aligned with the civility issue and with the fragmentation issue. And several important outcomes emerged. A faculty council was developed to create stronger representation and more regular communication pathways. So in that faculty council, there is a member from every single division, and they have some responsibilities about communicating back to their divisions that doesn't lie solely on the chief. A well-being specialist, so this is one of the things that cost money, a well-being specialist was created for the department. So that's somebody who reports to the department and has a dotted line reporting structure to my team. And that individual helps with civility and professionalism issues. And then communication flow improved overall, right? The chair is more efficient about getting information to the chiefs. Things are going to this faculty council. And so there's just this more kind of bi-directional conversation that's flowing better. And what we also saw is that there was increased engagement across the entire department because faculty could begin to see that the issues that they raised were going to be solved. So they started, now the chair even talks about that now, we start getting more opportunities for feedback and to create solutions because people now believe that we'll solve problems. So they're coming to us now with more problems. And so I think that is also just a change in trust and feelings of psychological safety. And when we go back to the title of this, when leaders listen, this idea for the chair to say, I'm getting more feedback now because of this process, tells me that leaders are listening. You can go to the next slide. Our internal medicine Department Enhancement Project is another powerful way of why root cause analysis matters. At first glance, compensation surfaced, as it often does, as the prominent issue. And often what leaders hear, when they hear that, the conversation quickly narrows because leaders will say, well, of course, compensation, but I can't pay more because of this or because of that. And so that often just stops and we don't explore the depth of what compensation really means. But we did the same process. We met with leadership. We transparently shared data. We engaged in focus groups, and we engaged the Solutioning Coalition. And we learned that it wasn't about compensation. What we found out is that APP and MA turnover was creating additional workload strain for physicians. Physicians then were saying, if I'm going to be asked to do more, then while my team's unstable, I want to be better compensated for it. So now we have a problem of APP turnover. Now we need to investigate that problem. So we found out that APPs were leaving because they felt undervalued in the department and insufficiently represented in leadership councils and other things within the department. So that was what we began to solve. So in other words, what looked like a compensation problem was a more deeply rooted problem of workload, voice, value, and representation of the APPs. And so if we had only solved for money in that case, we probably would have even gone anywhere because they would have said no, but we would not have addressed the underlying cultural and structural issues that was driving frustration. What came out of this is that the department generated solutions such as APP representation in all leadership groups and councils. They formed an APP council. And they created structures such as stay interviews, which we call RISE interviews, to better understand the retention challenges before people left. And I think this example illustrates why it's so important that the first issue people name is not always the root issue. Leaders have to listen if we want real improvement. You can go to the next slide. I've got some data that I can share about the internal medicine depth. So we did a pre-survey, a midpoint survey, and a project end survey asking these same questions. And we continue to use the same whole survey throughout our depth process. So we saw improvement across all of the 6 questions that were evaluated. Questions that looked at respect, feeling valued, employee input being sought, employee insights being used to create solution, and leadership's belief in inclusive problem solving and around psychological safety and challenging status quo. When we look at the numbers of these, it can be tempting to focus only on whether a score moved by a certain amount, and measurement matters, but I think that what we can see are these clear patterns of improvement across every dimension over this, 18 to 20 month period of time that it took for the Department Enhancement Projects to roll in internal medicine. And I think this is a picture of trust being rebuilt. When people say the input is actively sought, that their insights are used to shape solutions, and that they feel safer speaking up, those just aren't survey wins to me. Those are indicators of decreased burnout. It's indicator of an environment itself shifting in really meaningful ways. It's indicator of value and respect. And that's one reason why I really believe in this model of involving frontline clinicians directly in the change work. Because when we help people define the problem and shape the process, it becomes all of it is part of the intervention. Not only do we get a great solution out of it, but we get people feeling better. You can go to the next slide. So I mentioned that our department level work also helped inform system level change. We created in 2024, we created the Organizational Wellbeing Executive Leadership Team, or what we call OWBELT. OWBELT brings together executive leaders from the College of Medicine and UK Healthcare. On the college side, we have the dean, our vice dean, other members of my team, the Organizational Wellbeing team. And on the healthcare side, we have our executive chief medical officer, our chief medical officers, our CMIO, our chief APP officer, executives from nursing and operations, et cetera. We meet monthly, and the purpose of this is to simply discuss well-being, organizational well-being, climate, culture, et cetera, in a really broad scope, and simultaneously to create action plans. So we review our emerging survey data. We have, any thematic analysis from listening sessions. We share what we've cataloged through the Department Enhancement Projects. We overlay other survey data, and we look at all of this. We look at patient experience data, and we help it create a heat map of where we need to put energy and what those actions may be. And so we created an 4-pronged organizational action plan that I'm going to speak about just briefly. You can go to the next slide. So through what we heard from frontline clinicians, what we heard through other focus groups and survey data, we created kind of our first ever organizational wide action plan that was 4-pronged, and it crossed between College of Medicine responsibilities and healthcare responsibilities. So we were looking at strengthening leadership behaviors. We heard a lot about civility and professionalism issues, about the need for leaders to have higher levels of emotional intelligence. And so we wanted to make sure that that was something that was clear focus for us to work on as an executive leadership team for a year. And that was a College of Medicine responsibility. We also looked prong 2 at, we heard a lot about discrepancies between distribution of effort in one's like how much time they got for research time and teaching time and clinical time. And their RVU demands sometimes didn't allow for the teaching and research piece. And so we wanted to reevaluate everything and right size that. We heard faculty members saying, I chose to take less pay and work in academic medicine so I could do research or so I could teach. Don't take that time away from me. And so we wanted to make sure that was right sized. On the healthcare side, we looked at epic optimization. I mentioned that we rolled out ambient AI during this process, which in our ambulatory spaces so far, and that has been, very well received. And then we looked at our operational efficiencies, specifically within surgical services. What we heard time and time again through Department Enhancement Projects and survey data and focus groups, et cetera, was that even for our faculty who were not surgeons, they were not in the operating room at any time, the delays in turnover and other kind of just operating space timeliness, that was impacting their patients. And they cared about that. And so we really put a lens into decreasing OR turnaround time. And so I think this has been, and then what we did when we think about Leaders Listen is that we went to every department and we shared the proposed 4-prong action plan. We got feedback. We understood what success metrics would look and feel like. We began to implement the plan. We went mid-year of the plan and got feedback. We asked questions like, hey, we're working on DOE and RVU alignment or leadership strengthening behaviors or OR turnaround time. Are you feeling a difference? What would make these better? So another opportunity to listen. And then we have gone at the close as we're sharing press gaining data to say, okay, we rolled this out for the past year. Do we still need to focus on these 4 areas? What do we need to do differently in these 4 areas? Or should we replace one area with another goal? And so we're gathering that information right now. Next slide. So I'll close with some key learnings. First, I think before launching a survey or initiative, it's really important to communicate how feedback will be used, and not just to clinicians and frontline faculty about how this information is going to be used, but making sure that leadership, your executive leaders, are well bought in to the process, that they have an appetite for listening to feedback and really driving it into action, that they have an interest in allowing frontline clinicians to be seen as the experts in defining problems and solving solutions. So second kind of learning is that strong partnership with leadership is critical. If this would fall really flat, if we promised that this process would happen and then it didn't, it would have harmed our culture more than not doing anything. Third, faculty voice is essential. I think I've talked about that a lot during this, right? Through listening sessions and active action planning sessions, et cetera. It is so vital to get end user input and allowing them to be the leaders in creating solutions. Fourth, once a plan is activated, frequent and transparent communication is important. So through the entire DEPS process, there was communication constantly. After a DEP process concludes, we are still touching base with the department to say, hey, that APP council you put together, is it still in place? Is it doing what it intended to do? Just like we went back and said, here's the 4-pronged action plan at the system level that we're implementing. Does this make a difference? And finally, this has to be embedded into the culture. It cannot be a one-time campaign. So if we only do DEPS once in a department and we don't give them the lessons to replicate it, it's going to fall flat, right? We have to make this a part of our living, breathing essence of our culture. We want to keep repeating patterns over and over that we know that work. And I think when I think about shifting the narrative from no one listens to my feedback helped create change, it requires infrastructure. It requires visible accountability and this kind of shared ownership. The last slide. So that's a lot. I know I talk fast, but thank you so much for the time to be here today. I know that many organizations have the same version of the story that I encountered when we first came here, that feedback disappears. It doesn't go anywhere. Leaders don't care. Leaders don't listen, or we're not solving the right problems. And it gives me a lot of hope when I look at the improvements that happen in perception data that I showed you from internal medicine, when I hear people saying, oh, I talked to other faculty members about the DEPS process. It helps me see that energy around leaders listening and creating department and systemic level changes, that people are feeling energy around that. And our skepticism, while it doesn't change overnight, skepticism is declining. People really are beginning to understand that there's this bidirectional trust. I think that forms from that. So thanks again for allowing me to be here. I appreciate your attention, and I'd be glad to answer any questions or get feedback from you now. Thank you.
Lisa, thank you so much for that wonderful presentation. You've achieved some really wonderful culture change there, which does take time. We do have another good question here. When solutions cannot be implemented or addressed, is there a communication flow back to the end user? Do you sense that it affects the culture in a positive way or not when that happens?
So yes and yes. So if a solution cannot happen, we, especially in the Department Enhancement Projects, because we've got a little bit more locus of control in that, we go back to faculty. And in fact, we don't go back to faculty. The chair goes back to faculty and says, I understand that this is a solution that would solve this root problem, but because of A, B, and C. So we talk about the why of why it can't be implemented. We coach the chair in this conversation. So if there is an opportunity for evaluation of the solution down the road, that is said. If there is not, if this is off the table for forever, I want the chair to be clear about that, because I don't want to give people kind of this false sense of hope that the solution will happen. And so that, I think, helps build trust in I think people can be disappointed and trust being built at the same time. And I think that's what we see when we go back with that information.
Thank you. I had another curiosity here. On one of your slides, you mentioned a wellness person and or coach in at least one or more of the departments. And I was curious how their role really facilitates voice, and if they receive training or how they were identified.
Yes, great question. So in two of our departments, we have in one department, we have a vice chair for well-being. That's in our Department of Internal Medicine, a very large department. She is a physician that has gained some facilitation training. She does all of the rise or stay interviews. We meet monthly, so she feeds information to me. Of course, confidential information, but she feeds themes to me, and puts me in contact if people want to talk further about their any issues that they may have. And she holds some coalitions and does a lot of advocacy in the department. So when we think about ambient AI, she was a large advocate within the department for ambient AI to help. I'm not a physician, so it's very helpful to have someone in this vice chair role within a department who is a physician, because she's thinking frontline clinician needs around well-being space. In our Department of Surgery, an external hire happened for the well-being lead in that team, and she comes with a background in coaching and psychology and mental health support. And she offers a lot of one-on-one sessions and mediation sessions for surgeons, or maybe even for surgeons and APPs. She also does a lot of division level support. So if there is a division that's going through a lot of transition, or maybe they're having some communication challenges within that, she offers a lot of really direct support with that division and the individuals within it. And so we were looking, in that role, we were looking for someone who really had, a psychology or social work or some type of mental health support, who would be really good at facilitating dialogue.
Okay, wonderful. Thank you. Well, I just want to express our gratitude for your wonderful talk here. I know I learned a lot. Thank you so much. And Norma, do you mind going to our last slide here? We just want to remind our viewers that this is part of a webinar series. And our next virtual webinar is Tuesday, May 7th, from noon to 1 Pacific time. And that's From Overwhelmed to Empowered, Thriving in a Challenging Scientific Climate. And that's coming from a number of our affiliate faculty for the Center for Compassionate Communication at UCSD. So I'm very personally excited to watch this one and be part of that. So again, thanks to everybody for joining, and we'll see you next time. Okay, we'll hop on our other link.